Welcome to the pediatric cardiology intervention session. We had 4 lectures, but we will give 2 lectures because Dr. Abdel Fattah got a health problem ونتمنى له الشفاء ودكتور إياد برضو عنده emergency. So we will have 2 talks by Khaled Salaymeh and Al-Halabi. The first speaker is Dr. Khaled Salaymeh. He is a consultant interventional pediatric cardiologist. His talk will be update on adult congenital heart disease.
شكرا دكتور فخري، دكتور عوني، دكتور زيد، وشكرا لدكتور محمود. Thank you so much that you allowed me to give this talk. I will be brief because this is a big subject on a 15-minute talk. I think it's so important that even one of my patients I asked today to join us, and he's sitting at the back, he's 16 years old, that we did surgery for when he was a week old with coarctation of the aorta, and soon he will be joining the terminology adults with congenital heart disease. As you can imagine, that congenital heart disease is a wide range of structural abnormalities related to abnormal development intrauterine. However, we're not including any inherited disorders, including Marfan syndrome or HOCM. Also, we're not talking about any anatomical variants such as PFOs. As everybody knows, improved survival to adulthood is most striking for those with the most severe congenital heart disease, with survival up to 18 years of age reaching 90% in the most complex congenital heart disease. As you know, the embryology of the heart is the most complex in any other organ, so the most common anomaly of any organ in the body is the heart, and it represents approximately 1%. Patients with adults with congenital heart disease are a heterogeneous population, both in underlying anatomy and physiology, as well as surgical repair and palliation. So that means, yes, the number of patients in adults with congenital heart disease is increasing. However, due to the huge variation in anatomy, physiology, surgical repair, that means that in each small category, the number of patients remains relatively small. So due to the increasing number of adults with congenital heart disease, and in the US, the number of adults with congenital heart disease outnumbers the number of children with congenital heart disease, guidelines have been out for the past 16 years talking about adults with congenital heart disease. The first one was out by the ACC and the AHA was 2008, and then an updated version was 2018, and this is by the ACC and the AHA. And just to let you know that this is not done only by 2 groups, this actually included a huge number of societies in the US and international, including surgeons, electrophysiologists, echocardiographers, and statisticians. Again, the Europeans published their, in 2020, their guidelines for management of adults with congenital heart disease. In 2020, the first guidelines were in 2010. So it's out there that people have been talking about guidelines for adults with congenital heart disease. I will be, since I'm an American trained, so I will focus more on the ACC, AHA guidelines, and we will go through some of what their guidelines are and what their recommendations is. People have classified or gone through the congenital heart disease in adults into anatomy and the physiologic state, and they have classified the anatomical congenital heart diseases into simple, moderate complexity, and complex or severely complex. As you can imagine, the native diseases with isolated small ASDs or small VSDs or mildly isolated pulmonary valve stenosis, these are considered as simple congenital heart disease. And then any repaired condition from a PDA with no residual shunt or any cardiac enlargement or ASD or VSD, those are simple. And I just wanted to allude that if you have a patient who's like 25 and he had a PDA, either ligation or device closure, in infancy or even childhood. People now are saying, should we even follow them up in clinic when they are older or not? And I am with the follow-up every 5 years. Most of congenital heart diseases that have biventricular chamber and have had surgery or native are considered moderate complexity, and even if they are repaired or unrepaired. And most of those include coarctation, even sinus venosus ASD or septum primum ASDs, or tetralogy of Fallot repaired or unrepaired, and most of the congenital heart disease. That leaves the more complex congenital heart diseases that probably everybody knows: the single ventricles after repair, double outlet right ventricle, of course, the Fontan, interrupted aortic arches, transposition, either repaired with arterial switch or ascending procedure. The truncus is probably one of the most complex anatomies. So those are based on anatomical classifications: simple, moderate complexity, and then the great complexity. When it comes to the physiological state, people have classified them into 4 classes based on their New York Heart Association classification. Either those patients that have no symptoms and have no residual sequelae, they are class 1, and then 2, which either they have mild symptoms or mild residual issues intracardiac, and then the class 3, significant symptoms or residual lesions, and then of course the severe, which is grade 4, is the severe symptoms or patients with Eisenmenger or pulmonary hypertension or severe hypoxia. People have combined, when they want to classify adults with congenital heart disease, they combine the anatomical and the physiological state before they proceed to management of those patients. The guidelines emphasized on access to care. So they want to guarantee that there is a smooth transition of adults with congenital heart disease from a pediatric cardiologist to someone who is an adult-trained adult cardiologist with special training into adults with congenital heart disease. So this smooth transition is extremely important. Now, this is obviously in the US. In Jordan here, since we do not have someone trained in adults with congenital heart disease, I say that combination of an adult and a pediatric cardiologist should always follow those patients for the best outcome for such patients. And then, of course, that promoting the awareness that there is a lifelong specialized care needed for those patients on most of the congenital heart diseases. Now, the delivery of care is another issue. Most of the patients with congenital heart disease should be managed in all forms in collaboration with an adult with congenital heart disease cardiologist. And then if you have any surgery, catheter-based interventions, or electrophysiology, also should be in collaboration with such a specialty. How do you evaluate a patient that is known or suspected to have congenital heart disease? The number one thing is always 12-lead ECG. And we've seen so many patients that have adults with congenital heart disease that are complex, and they can present to clinic with complete heart block, and people have not been noticing that, with heart rates that are reaching down to even 45 or 40. So standard ECG with serial and also Holter monitors are mandatory in those patients. If you have someone with tachyarrhythmias, mostly tetralogy of Fallot, bradyarrhythmias like Stenting procedure after transposition, or complete heart block in LTGA or congenitally corrected transposition, Holters become a necessity. People try to avoid X-rays or any radiation because those patients have had multiple surgeries in the past. They've had a lot of X-ray exposure, so probably to limit such X-ray or ionizing radiation. Now, when it comes to echocardiography, as you can see, even the class of recommendation with the level of evidence, they first talk about the intraoperative TE. And I know in Jordan here, not a lot of people probably do intraoperative TEs for the repair of even adults or children with congenital heart disease, but that's a must because it guides the surgeon of what to go through in the OR. When it comes to transthoracic, obviously it's the basic tool, and then serial echoes are needed for such patients. I'll move to the cardiac MRI. The cardiac MRI, this is an essential tool, and you can see it's actually recommended as in green. So in patients with adults with congenital heart disease who are at risk of developing RV enlargement, which is mainly tetralogy of Fallot repair, serial, and I emphasize on the point, serial cardiac MRI is recommended for quantitative assessment of RV size and function. And then, of course, it can be used as an initial assessment for the RV size and volume. And just to emphasize the point for the newer generation, we do not have in Jordan anybody that can read cardiac MRI, and the only place we can do cardiac MRI, and they send the study outside Jordan to have it read, which is really something that we lack in our country. Computed tomography or CT angio is also sometimes can be useful, mostly when you need to assess coronary arteries if a patient who you're doing an intervention at the same time you don't want to do cardiac cath for the coronary, CT angio can be utilized. Cardiac cath, obviously, either for diagnostic or intervention. However, people are recommending that cardiac cath or intervention is to be done also in collaboration between when there are available people, adults with congenital heart disease. If not, a pediatric and an adult cardiologist would do that. And then if the patient is refusing cardiac cath for coronaries, CT can probably help. Exercise testing is needed, and I would recommend that people would do regularly exercise testing for baseline functional assessment, and sometimes people can use the 6-minute walk test to objectively assess symptom severity. I will skip for the sake of time because I have 4.5 minutes. They have also put guidelines for exercise and sports. I would emphasize on the point that a lot of our patients who are adults, they have mental illnesses because they are nervous and they are scared to die. So I urge patients that are above 20 years of age to be seen by a psychiatrist if you suspect depression or anxiety. Those patients who have arrhythmias and they are scared to die deserve psychiatric evaluation. There are some concomitant syndromes that our adult cardiology colleagues are not aware of, which is basically DiGeorge syndrome. They are very common in patients with congenital heart disease. So if you're faced with someone with a tetralogy or someone with truncus arteriosus, think about some syndromes, and you have to screen for them if they have not been screened. I will skip to the 3 cases since I have 3 minutes left, and I will avoid I already have prepared slides for pregnancy, contraception, heart failure. However, I have 3 diseases that I would like to talk about. They are common, and my colleagues, the adult cardiologists, would see them, which is number 1, it's the atrial septal defect. It's the most common that presents in adulthood, and you as cardiologists, adult cardiologists would face them. So the number 1 thing you do probably in clinic is just to check a pulse oximeter. It will give you an idea if your patient has reached late stages of pulmonary hypertension or not. If the patient's saturation is in the upper 90s, you probably not. And as you can see, the number 2 diagnostic test is the cardiac MRI, CT or TEE to look for the pulmonary veins, and obviously echocardiography is needed for the percutaneous closure. These are guidelines to talk about when to close, what to close, and how to close. If you have someone with pulmonary hypertension, 2/3 pulmonary artery pressure from the systemic, you probably ought to be careful not to close. And I'll present a case that we faced only 10 days ago, Iyad Hijazi and I, in Amman, that we probably did not close. And they talk about specifically about numbers, pulmonary vascular resistance, so things have to be studied very carefully. And obviously in red is when you have someone with Eisenmenger or right to left shunt across an ASD, closure is contraindicated. It's harmful for the patient. So I'll present May Hadidi. She's a 67-year-old lady diagnosed with 17 millimeter secundum ASD, presented to us last year after several echoes that have not picked up an ASD. Her SATs in clinic were 93. Echo showed the 17 millimeter secundum ASD and a TR estimating a PA pressure of 50 to 60. And Iyad Hijazi took her to the cath lab around 10 days ago and found that the pulmonary artery pressure was 60/30 with a mean of 40, and the systemic was around 100. So we decided to actually, let me just play that if I can. This is the video showing that We balloon occluded the ASD for 15 minutes, applied for 15 minutes. شكرا انك انت لعبت الفيديو. For 15 minutes, and then the pulmonary vascular resistance calculated at that time was 4. So Iyad decided not to close the ASD. It was big with pulmonary hypertension, and we decided to give her sildenafil for 3 months, and then ordered a fenestrated device, and we will close her in September. These are for the audience. This is an interventional meeting. Are the devices. To the left upper is the Amplatzer, and then next to it is the Oculitic. These are the two most commonly used. The Gore, which is the far right up, is much less used, and to the right lower is a new bioabsorbable device, but the two on the left side are the most commonly used. Tetralogy, can I ask for 1 or 2 minutes max? أكتر من هيك ما راح أحتاج. We're very close to getting done. So tetralogy of Fallot is those patients are getting older. They have been repaired in Jordan for so many years, and that's why you as adult cardiologists will face patients with adults that have repaired tetralogy. And as you can see, the number one investigation recommended is the cardiac MRI. So please emphasize the point that we need always cardiac MRI in those patients. Why? Because echo is not the best tool to evaluate RV size and volume. So you need cardiac MRI. Cath is not indicated in those patients to evaluate size of the RV. Cardiac MRI is, and if the RV volume is larger than 150 cubic centimeter per square meter, you need to replace the pulmonary valve due to severe, moderate to severe PR. Coronary test, artery compression test is needed before you do pulmonary valve replacement in the cath lab. And then cardiac catheterization is reasonable, but not necessarily most of the time. So these are the indications, and I don't want to spend much time, but I want to present a case for you before my last case, which is Mai Atari, is a 42-year-old young lady who's had tetralogy of Fallot repair in Toronto with VSD closure in 1982. She presented to me 3 years ago when she was pregnant, around 17 weeks, with severe TR, severe PR, dilated RA and RV with normal biventricular systolic function. We did a Holter. There was no arrhythmias. By the way, she was recommended by someone to terminate her pregnancy, but we did not terminate her pregnancy. She continued her pregnancy with very close follow-up and no change in her cardiac or New York Heart Association classification status. She delivered a baby girl, doing well, karma, and then we did a postpartum cardiac MRI that we noticed that her RV volume was around 190 cubic centimeter per square meter with a significantly dilated RV. We sent the MRI to Iyad to think, could there be a possibility of a pulmonary valve replacement, and it was too big for the replacement. We did surgery with a 25 millimeter freestyle valve and the repair of the tricuspid valve. This is her echo, and you can see how dilated the RV, but then the MRI showed us the exact volume, and she's doing well clinically. My last case is a case that's very dear to my heart. It's an LTGA who presented to me last year, but it's actually, as you can see on the first diagnostic, is always cardiac MRI. And then if those patients with LTGA, when they're older, there is severe TR, you need to replace their tricuspid valve. And if they've had, like my patient, a conduit between the LV and the PA that's stenotic, you need to replace it. So this is the last case. It's Mazen Bitar, is a 62-year-old with dextrocardia and LTGA, and his heart is exactly like this. The adult cardiologist who sent him, he said last year, Khaled, I don't even know which chamber connected to which chamber. So his right atrium it's dextrocardia, his right atrium connected to his LV, giving rise to the PA that was stenotic with a large VSD, his left atrium connected to his RV, giving rise to the aorta. He had in London at Great Ormond Street VSD closure and LV to PA graft with 22 millimeter Hancock valve. And he was referred to me with ascites and lower limb edema. We did a cardiac cath, maybe looking for constrictive pericarditis, and we found a very stenotic, you can imagine a valve that has been serving the patient for 50 years. I talked to Iyad and I talked to the surgeon in London. They both agreed that the main culprit for his problem was the very stenotic graft that was put in 1975. I sent him to Iyad in Doha. تلعب لي الفيديو بعد إذنك لو سمحت. تلعب الفيديو بس. This is the video sent to me by Iyad. He put in 3 bare metal stents as a landing zone, and then he put in a 23 millimeter my valve, which is one of the valves used to augment the RVOT, and did very well. It was a lengthy procedure with a lot of dye, so he ended up having a contrast-induced AKI, recovered in 4 days, and he's doing very well clinically. Those are the valves that are available in the market now for transcatheter pulmonary valve replacement. 3 of them, which is the Melody to your upper left, and Edward Sapien, and the My valve are balloon inflated valves, and then the self-inflatable valves are the rest of the valves. Most of the studies are done on the Melody and the Sapien. My valve is a new champ that's coming. Hopefully we can use it at the end. So the take-home messages are the number of adults with congenital heart disease is increasing, and survival of children with complex congenital heart disease into adulthood is reaching 90%. Guidelines are there to help caregivers provide the best possible care to adults with congenital heart disease. The presence of a cardiologist, and I urge my younger generation colleagues to be specialized into adults with congenital heart disease, because we don't have it in Jordan. And in the absence of someone like that, collaboration should be done always between a pediatric and an adult cardiologist. Cardiac MRI is an essential, I repeat, is an essential tool, diagnostic tool to help manage patients. Interventions in the cath lab have improved over the past 40 years. بعتذر من دكتور سعد جابر in helping adults with congenital heart disease to avoid surgery. Thank you so much.
Thank you. Yes, thank you, Dr. Khaled, for this interesting talk and nice cases. So we'll keep discussion to the end of the session. Thank you, Dr. Khaled, and we'll move to the next speaker, Dr. Elhalabi. He is a senior consultant pediatric cardiologist. His talk will be Aortic Isthmus Atresia.
Thank you, Mr. Chairman. Thank you, panelists. Thank you, Dr. Mahmoud, for the nice organization and persistence and enthusiasm in preparing this and preparing for this meeting. Aortic Isthmus Atresia. الباشا الدكتور يوسف كان هون قبل شويه فبسال الدكتور فخري بقول له ايش هي Aortic Isthmus Atresia. فالدكتور فخري بلش يشرح له، بعدين واحنا ماشيين اللي هو بقول لي هذه مره واحده خزقتها هي، قلت له ايوه هي اللي خزقتها هي اللي خزقتها. This is Aortic Isthmus Atresia is when you have no luminal continuity between the arch and the descending aorta. And it could be resulting from, usually it's resulting from long-standing coarctation. And this is why usually it's seen in adults rather than in pediatric patients. But however, in adolescents, you might find patients like this. It is probably due to no flow and the collaterals taking over. So by time, there's complete atresia. It is different from arch atresia, which with hypoplastic ascending aorta and interrupted aortic arch, because these are different entities. The congenital interruption presents early and usually in surgery early, and it's life-threatening. Okay, now different types of atresias or different distances of the atretic segment are there. So in this you can see it might be variable from 2 or 4 millimeters up to here you have 27 millimeters distance between the two segments. So sometimes the distance is too long between the two segments. So you have to be selective if you are going to intervene with these patients. And also, sometimes there is much malalignment between the upper and the lower segment. And if you have this, the malalignment affects your management in these patients also. It affects your approach and, of course, the possible complications that might occur. Also, there might be kinking, like this case, the MRI of this case. There might be kinking in case of interruption. Luckily, this case has a very short segment, so probably it is doable, but it's challenging. Now, talking about the technique of treating these patients, there should be radial and femoral artery access, carotid radial transseptal puncture, and Behrman in the arch for imaging. Very good imaging biplane. 3 approaches to open the atretic segment, either by hot wire, that's RF, or stiff wire, or by transseptal needle from below or even from above. Some people would do it. Okay? Of course, snaring and doing arterial loop is the best approach, because if you rail, when you are railing, you are more safe, and it's better for your outcome, and it's much easier. It makes your life easier, much easier, if you do arterial loop. Now I'll talk about some case series. This is one case series which use stiff end of 35 Teromo wire through 6 French GR from the brachial approach with angiography below to observe wire advancement, and arterial guide establishment by snaring the stiff end and advancing the GR, and then balloon angioplasty, serial balloon angioplasties, and then stenting with a Balmer's stent. Another series is 4 patients which use Nycanon RF wire perforated from above or below the cases, establishing an arterial loop and putting covered CP stents. 9 patients, all were perforated from below, 6 French transseptal system from the femoral artery, that's from below, and in 5, and RF catheter in 1, stiff end of the guide wire in 3/9. So sometimes the stiff end of wire works alone. I mean, can be tried and it might work, but you have to be very cautious because the stiff end of the wire is stiff, really. Covered CB stent was put. 3 patients, 19 to 14 years, and these are adolescent patients, from below, Advanta V12 covered stent, of course, in 2, and covered CB in 1. 49-year-old from below, hot wire, 40 kW kilowatt, and cutting energy. IVAS was used from left radial to axillary artery. Arterial loop was established. Covered CB stent was done. And here, no transseptal puncture was done. 9-year-old from below, 0.14 coronary guide wire, Teromo, crossed alone, and CB stent was done with no septal puncture. Now, the important thing in these cases is to serially dilate the stent, and not just dilate it right from the beginning to the maximum dilatation. Okay, so because if you do it at the end, you might end up with complications, aneurysm and complications. So you should be happy with whatever result in the first setting, and then go for further settings of dilatation. Now, this case is a case of, as I said, aortic isthmus atresia. And as you can see, the area between the upper and the lower parts is short area. Here is a catheter in the upper part, and here is a snare in the lower part. This was perforated, the upper part was perforated, and the wire was snared down, a loop was created, and a sheath, 12 French sheath, was introduced from below through the interruption, through the atresia, and then a CB stent was put, and it was dilated. Now, however, after this dilatation, the left subclavian was jeopardized. It was closed completely. So recanalization by perforating the BTF of the covered stent was done. and a wire was no, that was done by a transeptal needle, and the wire was snared by a snare from the radial, and then serial dilatation of the stresses of the stent were done until there was good flow through the subclavian. So tips in these cases: always do very high quality angiography and probe with a guide wire. Always have surgical backup and blood ready, because things might go wrong. You might have bleeding at any time, and you might have to send the patient to surgery. So surgeon should be there, and you should be ready for surgery. The take-home message is that isthmus atresia can oftentimes be dealt with safely and effectively in the catheter lab. Various perforation equipment can be used. After recanalization, covered stents are implanted always. Always have a plan for recanalization of the subclavian if at risk. Thank you very much.
Thank you.
خلينا نعمل discussion معنا شوي.
Any question? Okay, well, any question, please, from the audience?
Yes, I have a comment about the Dr. Ali about aortic isthmus atresia. Sometime obligatory, sometime we have to use non-graft stent. Oh, sometime all the cases use graft stent for treatment. Is there any cases need non-graft stent because of the close origin of the left subclavian artery to the atresia? Yes, yeah. Thank you.
Well, it's usually these cases will need covered stents, always, because you have a defect. You have an area which is bare. When you perforate, there is an area which is bare area. How are you going to put a stent which is not covered? يعني you are using the cover in order to establish the continuity between the lower and the upper part. So there's no point in putting uncovered stent. عشان هيك, even this patient who had, as you've seen, who had the subclavian very proximal, we closed the subclavian and then perforated it with a transeptal to reestablish the flow.
Yes.
So you always you have to
But sometimes you didn't find a good landing zone for putting the graft stent.
landing zone is always there, because you have the upper part is closed and the lower part is closed, and this is by itself is a constriction.
Yes.
So this is a landing zone.
Yes. Other question about the association of sometime during treatment of correctation of aorta, use the same procedure and put sometime non-graft stent.
No.
But I ask you about the during inflation of the balloon, patient with correctation of aorta or aortic atresia sometimes have aneurysm in the brain, perianeurysm, and this is carry a high risk for intracerebral hemorrhage. Sometimes use the procedure of rapid pacing. This is done by you?
Yes. The best thing is if you are afraid of the stent moving during inflation, is to use rapid pacing.
No, I mean rapid pacing to decrease the pressure during inflation of the present part of
okay.
aorta.
The movement
Yes.
is due to the
Yes,
high pressure.
Yes. Use the rapid pacing in
Yes.
some cases?
Yes.
All cases or some?
Yeah, most of the cases.
Thank you. Other question, please.
These patients, these patients are usually hypertensive, and the hypertension would not improve like this patient. Usually it doesn't improve. Well, it improves, but it doesn't disappear. So by all means, they need the follow-up for their hypertension. Regarding their stenting, once you reach the full stent inflation, then a follow-up of 6 monthly or yearly will be enough. But it's a long way to go there. Screen for what? For what?
Like, does it run in families? Do you have to screen their brothers, sisters?
It's as I said, it's secondary to coarctation. And coarctation, as we know, unless associated with certain syndromes, doesn't repeat. The incidence of repeat is like almost like the general population. So I don't think they need screening. Themselves, they need screening for various aneurysms and yeah.
اسمح لي فخري أضيف هون. Ayman, this is a very good question because you guys see some adults with coarctation. معلش coarctation كمان is an adult with coarctation, or you might inherit, like my patient who's sitting at the back, a child who had coarctation repair and now he's 20, 25, 30. There are 4 things we tell adult cardiologists to follow in coarctation long term. Number 1, restenosis of his coarctation. But if you have a stent done at the age of 20 or 25, it's unlikely. So you keep balloon dilatation of that stent. Number 2 is hypertension. And usually kids who have repair less than 2 years of age, it's unlikely that they might have hypertension when they are older. However, it is a potential, always. Number 3 is cardiac function long term. Especially in your adult patients, coarctation adult patients who've had repair or stent later on in life, they are at risk of developing LV dysfunction. And number 4, always screen for bicuspid aortic valve. 80% of coarctation, they have bicuspid aortic valve, and I always tell my patients that long term, when you're 50 or 60 or 70, this valve might become stenotic and leaky. So those 4 issues are long term for adult cardiologists to follow on coarctation long term. Thank you.
May I have one comment here regarding the perianeurysms, as our colleague mentioned. In adult age group, before intervention to the coarctation issue, we do brain MRI to look for perianeurysm, and then after that we proceed.
This is very recommended. I ask about the duration of dual antiplatelet to keep the patient on dual antiplatelet or single antiplatelet for how long duration?
Well, these patients, we usually keep them only on aspirin because it's a high flow, wide area. We don't usually, after aortic stenting, we don't give, we get only antiplatelets.
Yes.
Yeah. I don't know what's the practice of other colleagues. Aspirin, yes. Yeah, that's just
Single
aspirin.
yeah. I have a question to Dr. Khaled about the role of the TAVI nowadays, MyValve and Edward, used for treatment of congenital adult pulmonary stenosis. I want to ask, it's the role of the use of the size of the valve. Is the same for the aortic stenosis? I mean sizing of the annulus, and what is the rules?
Actually, the TAVI has been reserved for much older patients with severe aortic valve stenosis. In our patients, we are not tackling, in kids, we're not tackling aortic valve by interventions at this current time. Is MyValve being used in the adult aortic valve stenosis severe? I really don't know. I have to ask Iyad if they do. And I'm not aware. Is Hussam Suradi is available, who اجى سلم عليه. Hussam would know because Hussam is a structural cardiologist who does always TAVIs. He does 200 TAVIs a year. From our point, MyValve mostly used for pulmonary. I'm not aware that it's actually being used for aortic valve stenosis, unless you Ali know it is.
Yeah, MyValve was, it's an Indian valve. And
Dr.
it is
1 minute.
formed, okay. It was structured and designed for the pulmonary.
Yes.
Okay, so and it's recently
They put
used.
the
It's very
valve
good.
upside down.
Yeah.
Upside down.
Yeah, I know.
And sometimes in Indian and some schools use cover stent to the pulmonary valve,
It should-
and then fix the valve, because
The
in this case,
yeah, the MyValve needs a stent. It
yes,
is a
because
valve and a stent.
the role in TAVI, we deal with elderly cases with calcified aortic stenosis, and the calcium make fixation to the valve.
Yeah.
And in cases of congenital pulmonary stenosis, there is no calcium. So how we can fix the valve?
Yeah, the idea is that there is a conduit, and you, the valve, معلش, half a minute. The pulmonary valves are two types. The one, Dr. Khaled showed them. One of them is like the Sabine and the Myval and the others that need a rigid place to be put in structure,
Yes.
which they need pre-stenting. The other type اللي هو Polsta or Venus or Harmony,
Yes.
Harmony, they don't need, okay? Because what they is that they stay and open in the outflow tract. However,
This
the
mean
problem with those
radial
others is
support,
that you
big
need
radial
a
support,
longer
yes.
outflow tract,
Yes.
okay? And a smaller outflow tract, because you cannot
Yes.
Yes.
have a... Yeah.
Thank you, Ali. We'll proceed to the last.
Our next speaker, may I invite Dr. Iyad Al-Ammouri. Dr. Iyad is a consultant pediatric interventional cardiologist. He will be talking to us about stenting of ductus arteriosus in congenital heart disease.
Thank you very much. Thank you, Mahmoud. Thank you, Aouni, and all the panel. I know you have been talking about congenital heart disease in adults, so this lecture might be a little of a change because it's going to talk about neonates with complex congenital heart disease. So the objective of this talk is to give an overview of which congenital heart disease requiring ductus arteriosus, rationale to stent the ductus as an alternative to surgery, the morphology of the ductus, the technical aspects, and examples from Jordan University Hospital. So this is a brief indications for ductal stenting. A patient with pulmonary atresia without any flow to the lungs, he will need a ductus arteriosus at birth. Pulmonary atresia with a VSD, also no flow except for the ductal flow. Tricuspid atresia, there is no flow into the RV. And in cases where we have no VSD as well, they need a ductus. And many other variants like single ventricle with pulmonary atresia, transposition with severe pulmonary stenosis, many indications. So ductal stenting, the first actually kind of a normal ductal stenting was, or creating a ductus was by Blalok-Tosic. When they created a shunt that is similar to a ductus, so it's similar to a physiologic thing. So this is Blalok-Tosic in 1944, where they created the surgical shunt. So it's still a surgery, sometimes need cardiopulmonary bypass, long recovery time, and many, many complications. So the rationale is to stent the ductus, which is a normal structure, and keep it open for a while until we have the surgical procedure. The first report was actually a long time ago, so the idea is old, but the technique was not mastered because of the technology and the use of smaller things to be able to put in small babies, like a 2 or 3 or 4 kilo babies. So there have been a lot of literatures about stenting a ductus, comparing it to Blalok-Tosic shunt, and actually it's either the same or even better than doing BT shunts in terms of complications and in terms of growth of the pulmonary arteries. If you look at the ductuses that we usually stent, because of congenital heart disease, they are usually not normal ductuses. So it's not the usual ductus that we know that we close in the cath lab sometimes. This is usually complex lesions. So for example, you can have a ductus that is vertical, you can have a looped ductus like this, or a very complex with multiple loops. And the origin of the ductus can be from the normal origin in the descending aorta, or can be from the underside of the arch, from the subclavian artery, or from the innominate artery. So many, many planning that has to be done before you do the ductal stenting. So the procedural consideration, we have to do pre-procedure planning. A lot of planning and patient selection has to be done. Imaging to define where the ductus comes from and where does it insert and the length, etc. Plan your vascular access, because we can access it from the femoral artery, but we can also access from the axillary, from the carotid artery, from the venous side, and cross a VSD or cross a pulmonary valve into the ductus in retrograde fashion. Ensure availability of equipment. Prostaglandin infusion has to be present in the cath lab. Usually we stop it a few hours before or just in the cath lab, but it has to be available in case ductal spasm happens. Anesthesia usually is required. Biplane imaging is very important. Heparinization and obtaining access, and blood pressure should be maintained throughout the procedure so that we have a patient who is stable. Vascular access, depending on where the ductus comes from, it can be, as we said, femoral, it can be from the axillary, carotid, from the venous side, etc. I was asked to do the lecture in 7 minutes, so that's why I'm just in a hurry. So we have to select the length of the stent that we're going to use. We have to select the diameter, and this is just a general scheme that I use for stenting ductuses. If a patient is above 3 kilos, then we use a 3.5 to 4 millimeter ductus. If it's 2 to 3 kilograms, then we use a 3.5. If it's less than 2 kilograms, then a 3 millimeter ductus. But this can change depending on what's the outcome of the patient that we are anticipating. If the patient needs the ductus for a long time, then we opt to enlarge it a little bit. If we only need it for a couple of months until the patient has surgery, then we might put a smaller one. And depends on other sources of pulmonary blood flow as well. So this is a new report showing that ductal stenting is actually better than blood toxic shunt in terms of mortality and in terms of freedom from re-intervention for cyanosis, and in terms of growth of the pulmonary arteries, and in terms of the symmetry of the pulmonary arteries. So when you stent a ductus, it tends to have symmetrical flow to both pulmonary arteries rather than the BT shunt, which tends to give flow preferentially to one or the other pulmonary branch. Of course, we have a lot of complications that we have to anticipate and try to avoid, such as vascular injury. Those are small babies with relatively larger stuff that we put in. Stent thrombosis, ductal spasm during the procedure, jailing of branch pulmonary arteries, etc. We started doing ductal stenting at Jordan University Hospital in 2012. And we selected those patients because they are more straightforward than the other ones. And we usually cross from the RA to the right ventricle, and then we perforate the pulmonary valve, balloon the pulmonary valve, and then put a stent in the ductus, because the right ventricle usually is not able to pump all the circulation. So it needs a little bit of more flow into the pulmonary artery, so it gives the right ventricle time to adapt to the new situation. But we also, since that time, we have done also patients with tetralogic fallow, patient with tricuspid atresia, patient with pulmonary atresia, and even a patient with transposition of great arteries with severe pulmonary stenosis and VSD. So we also stented ductuses there. So this is just an example of a patient who had pulmonary valve atresia with intact ventricular septum. There's nothing going through the pulmonary valve. We perforate it with a CTO wire, and then we balloon the pulmonary valve. This catheter here, this is a lateral projection. This catheter is across the ductus. You can see the catheter actually went into the pulmonary artery. We ballooned the valve. We tried the patient off prostaglandin. He did not recover, so we had to bring him back in a week, and we placed a ductal stent. See, this is the ductus arteriosus, and it's very narrowed. We placed this ductus, we approached it from the right ventricle. So venous side, RV, pulmonary artery, across the ductus into the descending aorta. This is a 5 French Judkin right guide catheter. So this is the placement of a stent. And after stent inflation, very good flow into the duct. This is how it looked by echo. After 2 months, this stent is across the ductus arteriosus with good flow across it. This patient is now having 2 good ventricles. We can also do that at the time of the pulmonary perforation, so we don't have to wait and see if the patient can accommodate. If the RV is very small, this RV is very small. All this is right atrium. The right ventricle is very small and hypertrophic, so we perforated the pulmonary valve, we ballooned it, and then at the same procedure, we just crossed the ductus and placed a stent. And so the patient now has 2 sources of pulmonary blood flow from the right ventricle and from the ductus. Now this patient is already 5 years of age. He has 2 good ventricles, and there is minimal flow across the ductal stent. We leave it for the time it will occlude by itself because the patient does not need it anymore. Sometimes those patients, we cannot perforate the pulmonary valve if the pulmonary valve atresia is not membrane-like. So this procedure will be ductal stenting as palliative procedure. So this patient has a very severe narrowing of the ductus, very blue patient, and we just placed a stent, and the patient went on to have single ventricle palliation. So we did publish our case series for this particular patient, and out of 15 patients, We have 12 with 2 good ventricles. So the biventricular outcome is almost 80% of patients. One had univentricular outcome, 1.5 ventricle, and 1 mortality. A patient with tricuspid atresia. Now remember, this tricuspid valve is closed. There is no VSD, so no blood flow to the lungs. This patient has only one source of pulmonary blood flow, which is the ductus arteriosus. This ductus is very, very abnormal in shape. It's like has 3 curves. So if you look at this, it's like this one. This is lateral projection and anterior projection. So this patient requires a ductus. We crossed from the arterial side 2 wires just to have more stability and straightening out of the ductus so that we can get a good measurement. We place a stent based on our measurement. The stent has to be covering the whole length of the ductus, so that's what we did. We placed the stent based on our measurement, but it's a little short on the aortic side. So what we did after placing the stent, this is a good placement of the stent. Let me see. Okay, let's just go. Okay, so good flow across the ductus arteriosus, but it's missing the aortic side, so we had to put another stent. So another shorter stent that was placed in the proximal end of the ductus, and this patient has, she's now waiting for her gland. This is the final result with stable ductal flow into both pulmonary arteries. Another patient has tetralogy of Fallot, which is a different pathology. This is the right ventricular angiogram. There is severe subpulmonary obstruction or right ventricular outflow tract obstruction. The patient has right aortic arch, so the aortic arch is mirror image. His ductus, however, is coming from the left brachiocephalic. So this ductus is very long, and it's also narrowed at its proximal, at its pulmonary insertion. So this patient, the pulmonary stenosis is severe, so he depends on the ductus for survival. So we had to stent this ductus from the arterial side. We placed a stent here at the distal end, but again, we have to cover the whole length of the ductus because it will just shrink if you don't cover the whole length, because it's not a normal vessel. It tends to spasm. So we placed another stent and another stent. We thought we were done, so the patient is better, and then suddenly he had severe cyanosis. We did an injection. There is acute stent thrombosis, so the whole thing actually thrombosed. And so what we had to do at that time, we had to re-access the ductus. We put antiplatelets, although he was heparinized, into the stents, and then just put balloon through it. And this is the final image. So good perfusion into both lungs. Although jailing part of the left pulmonary artery. This patient had just had his full tetralogy of Fallot repaired just a month ago, and he's really doing well. So I have not seen him after surgery, but I heard that he had full repair in one of the private hospitals. Another patient now, a different pathology, pulmonary atresia with VSD. Those are also very challenging patients, especially in our area of the world. So they usually need multiple surgical procedures to rehabilitate the pulmonary arteries, sometimes multiple surgeries, right and left thoracotomies, and then connect them together, and then put a conduit from the RV, keep the VSD open, and then close it later. So it's really very laborsome disease. So this patient had also right aortic arch, very tortuous ductus into both pulmonary arteries. There is no main pulmonary artery, and you can see that there is stenosis at the right pulmonary artery. So we tried to cross with manipulation. There is spasm, and we lost flow to the LPA as well. So this is during the procedure. The patient became unstable. He's very blue. So we had to access the LPA quickly and put a stent that actually reestablishes the flow to the LPA. And we decided to stop there because the patient was unstable to try to cross to the RPA. So in conclusion, ductal stenting is technically possible for most morphological variants of PDA, a good alternative for BT shunt surgery, and can be done as a sole procedure or in addition to other interventions in the same baby. Procedural planning, including patient selection, morphological considerations, technique, access, and equipment availability is very important. And there is significant advantage in terms of ICU and hospital stay when we compare it to the Blalock-Taussig surgical shunt, advantage in pulmonary artery growth, advantage in pulmonary artery symmetry, and the need for reintervention for cyanosis. Again, this procedure is a palliative procedure, but can be a definitive procedure in some patients, particularly the pulmonary atresia with intact septum. So they just need some time until the RV becomes more compliant, and you will end up with 2 good ventricles in most of those patients. Thank you.
Thank you, Dr. Iyad. We have 5 minutes for a question.
يعطيك العافية دكتور إياد. I start my question, as you mentioned, in horizontal ductuses, it's maybe quite feasible to go through the femoral axis, whereby in vertical axes maybe cut off carotid approach or axillary. So
Right.
first question is, when you have long ductus with the proximal LPA or RPA stenosis, how you manage that? And second one regarding prostaglandin, when neonatal prostaglandin, when you stop your strategy and you continue the procedure.
Yeah. Very, very good questions. First of all, if you have, in addition to the ductus that you are going to stent, if you have branch pulmonary artery stenosis, the strategy is to try to stent, to extend the stent into the branch pulmonary artery stenosis. So if you have an origin of the LPA that is stenotic, you just go with the stent across, jailing the right pulmonary artery. That's fine, because at the time of next surgery, they will deal with that. You can also cross through the struts of the stent into the RPA and just balloon dilate the struts of the stents. Those stents are coronary stents, and they are open cell design, so you can just balloon through the struts, which will preserve the flow to the contralateral pulmonary artery. So if you have branch pulmonary artery stenosis, you can stent across it, and that will be dealt with by Dr. Zaid once he does the surgery. So he will remove the stent into the pulmonary artery and just do PA-plasty. So that's one question. Regarding the access, this is also very important. That's why the selection of patients and planning is very important. A very good approach is actually to go to the venous side. So patients with pulmonary atresia intact septum, you perforate the valve and go from the pulmonary artery into the descending aorta. This is a more straightforward, and you can accommodate a 6 French sheath and 6 French guide or a 5 French guide. But from the artery, femoral artery, you can't go more than a 4 French catheter. Sometimes I'd go without a guide catheter. So just based on where the ductus is, and just do some mapping of the ductus. If the ductus is vertical, I still sometimes go from the femoral artery. Once I used a Judkin left coronary artery, a pediatric coronary artery, which is like a 1.5 curve, and it can give you the curve downward. But the better approach is actually right or left carotid, depending where the ductus comes from. This will need a carotid cut down and then carotid artery repair. So I'm reluctant to do that without surgical backup. Now, another good approach for pulmonary atresia with VSD, you can go and cross the VSD and go to the arch. Once you go to the arch, if you put a Judkin left catheter, a Judkin right catheter, it will point it down, or a cut pigtail, it will point the catheter down into the vertical axis. We've done that also, and it was a very nice technique to go from the RA to the right ventricle across the VSD into the aorta, and then come to the vertical ductus. So it just needs planning, and you need equipment. So you need to be prepared what equipment you need in order to get access to the ductus arteriosus. I don't know if there was...
Prostaglandin.
Yeah, prostaglandin. Prostaglandin, we usually like the prostaglandin to be available. Some operators stop it a few hours before. I personally stop it on the way to the cath lab. So I stop the prostaglandin in the NICU on the way to the cath lab, because I need the ductus to constrict a little bit so it holds the stent. Because once I stented the ductus that was large, and it did not hold the stent, so the stent migrated into the pulmonary artery, so I had to stabilize it with another stent into the ductus. So you need the ductus to be a little constricted so it holds the stent, because many ductuses, you will have a large ampulla and then very narrow area that is very short. So you need that short area to hold the stent. The large ampulla will not hold the stent. So I stop it before the procedure, but I keep it connected to the patient, so in case we have ductal spasm, we just restart it on. If we fail the procedure, then we can restart the prostaglandin.
Thank you.
Yeah. Please. Yes, sir.
Dr. Khaled.
Yeah, thank you so much for your amazing talk. I want to urge my colleagues in the private sector, and including myself. I even talked to Iyad yesterday about a fetal echo. we diagnosed the baby that's actually term next week, probably will deliver, that has pulmonary atresia intact septum, and I urge the mother to deliver at the Jordan University Hospital. My point is that these procedures are expensive and the learning curve is not easy, and Iyad has been doing them since 2012. It's really great to pour most of our cases, because they need money, training, and a lot of resources, is just to pour them into JUH so that we keep going, and that makes the experience at JUH really fruitful and the outcome. If you ask me, Iyad, and you ask me to do a PDA stent now for any form of congenital, I would refuse, because you do it better than I do, and the insurance companies most of the time do not cover congenital heart disease, and then if you need a stent or 2 or 3, that adds up, so people would pay too much. I urge everybody to pour those cases that require PDA stents in neonatal life to JUH, so that Iyad would build up more cases, have better experience, and then we save obviously more babies. Thank you.
Thank you very much, Khaled. Yeah, the important point is really planning, and many patients now we diagnose them in fetal life. So we had a patient 2 weeks ago, actually, بالعيد, I had a patient transferred from north of Jordan with diagnosis of pulmonary atresia intact septum, but because he had a period of hypoxia, when he arrived to the hospital, he was not moving, and we thought that he had the brain insult. So we had to postpone the procedure for 1 week until he recovered on prostaglandin, and then we did it. And he probably has some residual CNS insult. So I think planning is very important. Not necessarily at JUH, maybe الخدمات, anywhere where the expertise is present, just plan the procedure. Have the baby born in a hospital that can deal with this, because transferring the baby from north of Jordan to the middle, or from the south to the middle, with very severe hypoxia, particularly sometimes with absence of prostaglandins in some hospitals, the patient might get significant hypoxic insult. So, yeah, Dr.
Thank you very much.
Iyad, fantastic presentation, and the results are really, really good. I find it much better for the patients to have a stent rather than having a shunt, because still the shunts carry a high risk and mortality around 18 to 19% in the STS data. And that is a comment. I find it, for the cardiology, it's much easy to go for the subclavian. So I do the subclavian cut down for them, put the sheath, the 4 millimeter sheath, and that's it. It's easy job for them. So they are better off having the subclavian, especially if it's vertical and difficult to handle. Sometimes they try the femoral, but they end up with the subclavian approach. And my question is regarding when do you go for RVOT stent versus PDA stent?
Yeah. I don't go for RVOT stent. I don't have experience with it.
But RVOT is more.
Yeah, I know it's gaining more importance now. The right ventricular outflow tract stenting only in patients with tetralogy of Fallot, so that's a subset of patients. The patient that I showed you, there is severe subpulmonary obstruction. The alternative is to do a subpulmonary stent in the RVOT. I personally don't have experience with it, although it's the same tools that we use. But I'm just concerned about stent fracture, because of the RVOT is very dynamic, so it might fracture the stent. And then when you do that, then you'll have to have a plan with the surgeon who's going to bail you out if you have a problem, or we have a time set for the repair in 2 months or 3 months. Many of the patients that I do, they don't have a plan of repair in 2 months or 3 months, so I don't know when they're going to get to do the surgery. I had patients waiting for 12 months, waiting for a Glenn, Syrian patients without an insurance. So sometimes I prefer the ductal stenting rather than an RVOT stent that will fracture if you leave it long enough. So it might stay for a month or 2, but I think it needs, then it will fracture. The other option is stent embolization is much more common in RVOT stenting rather than PDA stenting. I really appreciate that I'm hearing this from a surgical standpoint, that he says, go ahead and do it because it's better than BT shunt. And I really appreciate, Zaid, that you're starting also to support your colleagues doing stenting.
Yeah, very supportive. I mean, it's better for the patients.
Yeah.
The outcome really, they sell nicely more, with the stent rather than having the shunt. My last comment about the RVOT stent, since you perf in the atresia patient, perf the membranous atresia, so it's wise sometimes just to, deploy a stent there.
Yeah, well, I don't recommend that. Actually, I do not.
I agree with you. Sometimes the compliance of the LV, of the RV is not that good, so the antegrade flow is not going to help you out, especially in the interior, in the first, few weeks.
Yeah.
So you might end up with putting another ductal stent for the same patient, isn't it?
Yeah. Well, for that subset of patients, pulmonary atresia intact septum, there's a lot of literature. If it's a membranous atresia, I really do not recommend RVOT stenting because the patient will then definitely have to have surgery done. Many of those patients, they end up with biventricular repair without any other intervention, maybe just a coiling of the stent if it remained open. So the outcome is much better if you just do the PDA stenting and open the valve rather than to put a stent in the RVOT because the patient then will definitely need a surgery. But in my series, 80% did not need any surgical intervention afterwards. So you just perforate the valve, balloon it, and put a stent.
Marvelous job, Iyad.
Thank you very much, Dr.
Thank you very much.
And coffee break.
Cafe break. Yeah, thank you.